Thank you, Dr. Tehrman, for presenting on shared decision-making. I'd like to invite Ms. Sandra Rome to share us our first case study, Mary.
Thank you. So we have several case studies that we're going to talk about in terms of the trajectory of our multiple myeloma patients being treated. Mary is a 66-year-old retired librarian. She's married. She was active and generally in good health. In November of 2018, she presented to the ED with severe back pain. An X-ray showed a fracture of a spinal cord compression at the T1, and you can see that in that picture there. Also, other lytic lesions, and her creatinine was elevated. So how do myeloma patients typically present? Well, you can see at the top, oftentimes, such as in Mary's situation, they come to the ED with a severe back pain and often spinal fractures, and maybe some renal failure, abnormal labs, etc. Some non-emergency presentations might include they visit for a specific complaint, maybe they just have had this low back pain for a while, abnormal test results, maybe their creatinine is elevated, etc. Or maybe just on a routine physical exam, patient with few to no symptoms, maybe they see an increase protein in their urine, etc. So both of these situations, of course, we have to take care of the emergent problem, but with a non-emergent presentation, there's a little bit more time for some shared decision-making. So Mary presented with that horrible, painful bone lesion, and as we know, that can be an emergency when you're thinking about an impending spinal cord compression. Of course, if there's a solid plasma mass, that can be locally irradiated either in the spine or in other bony parts. Generally, though, if you have a lytic lesion where the bone really has a space in it, you need to fill that space. And so we have options such as vertebroplasty, where bone cement is injected to stabilize the spine, or kyphoplasty, which uses a special balloon to create a space within the vertebra, and then bone cement is placed, and that restores the height to the vertebral body. Orthopedic surgery also may be used to pin a long bone if that is needed. So the diagnostic workup for multiple myeloma, Joseph and Beth talked a little bit about this, but of course we have many lab tests, so they're looking at that serum protein electrophoresis. They might look in the urine for also those abnormal proteins. They're going to do a CBC and differential and chemistry, and they're going to look at the albumin to see if it's high or low, and they're going to look at these non-specific inflammatory markers, beta-2 microglobulin and LDH. They're going to look at the free light chain ratio of the kappa and lambda light chains that we talked about, and a monoclonal protein analysis to see what abnormal protein is presenting. And you can see again that spike on the SPEP there. Of course, a definitive diagnosis is by the bone marrow biopsy, and with that, they're going to do FISH testing, cytogenetics to see if they have some high-risk features, maybe some gene expression profiling, and maybe some plasma cell studies that look at sort of the virility of how fast the myeloma cells are growing. And then, of course, imaging studies. So as we saw with Mary, a lot of times the first diagnostic test might be a typical skeletal X-ray, and those really, in terms of screening for significant bone disease, are not really the standard once you've thought about that the patient has myeloma. So a whole body low-dose CT scan is the best for early screening for bone disease. A PET CT scan might be done for a response assessment, active residual disease, and then a whole body MRI of the spine and pelvis. That's sort of the gold standard to assess further bone marrow involvement. DEXA scans really are not useful unless, of course, you're working somebody off for additional osteoporosis. So then the patients need to be staged, and this might look a little busy, but it's easiest if you look at their stage 1, at the bottom there's stage 3, and what's not stage 1 or 3 is stage 2. So stage 1, you can see, and this was actually based on thousands of patients, and they looked at, okay, what variables are the most important in terms of looking at 5-year overall survival and 5-year progression-free survival. And what they found was it was these sort of non-specific markers like serum beta-2 microglobulin. If it's low, if they maintain their serum albumin, so that is fine. If they have no high-risk cytogenetic features and their serum LDH is below the upper limit, which is about 250 for a lot, 250, 260 for a lot of institutions. So those patients would be stage 1 with an 82% 5-year overall survival and a 5-year progression-free for survival. Stage 3, on the other hand, is with an elevated serum beta-2 microglobulin, high-risk cytogenetic features such as deletion 17p or translocation 14-4, and or a high serum LDH. And you can see the 5-year and progression-free survival were much higher in those patients. And then, as I said, stage 2 is in between those two. So let's get back to Mary. So Mary, of course, she had her peripheral blood drawn. Her calcium is actually fine. Her albumin was a little bit low of 3.3. Her beta-2 microglobulin was actually a little elevated, 5.3. Her LDH was actually not elevated significantly. Her creatinine, however, was 2.1, and her GFR was also reduced. Her hemoglobin was a bit low at 10.8, and she did have kappa light chains on her peripheral smear, and her kappa lambda ratio was significant as well. Of course, the bone marrow biopsy showed she had 60% plasma cells that were kappa, and her cytogenetics show that they were normal. She didn't have any of those nasty cytogenetic markers that we look for. Her whole body low-dose CT showed that she did have additional lytic lesions in her arms, ribs, skull, and femur, and so she was diagnosed with active myeloma, revised International Staging System, stage 2. So, now that we have some time with the patient to talk again with that shared decision making, there are so many options for our patients. And so, and you're going to hear throughout our talk here how, the treatments can change over time. They're very patient individualized, and really staying on treatment, not that there can't be some sort of rest in between, but really staying on treatment is paramount for the survival of these patients. So you can see on the left front line, there's a whole smattering of options for patients. If the patient is frail or very elderly, maybe they got some renal problems, all those things are taken into consideration, and maybe they're going to recommend a 2-dose regimen, such as bortezomib and dex or lenalidomide and dex. For patients that are a little bit more robust, and again, this is not necessarily age-related treatment, they may recommend, or through the shared decision-making process, decide on a 3-drug regimen, so bortezomib, len, and dex, or carfilzomib, len, and dex, and then some newer therapy regimens, combinations such as bortezomib, melphalan, and daratumumab, so a 4-drug regimen. And then, of course, autologous stem cell transplant is an option for many patients. And then, of course, there's maintenance. We're going to talk a little bit about that later. And then there are all sorts of options at relapse. So ixazomib, pomalidomide, daratumumab, a variety of agents that are often in combination as well. And then throughout the trajectory, patients may consider new clinical trials, and there are always those that are available, and Beth mentioned some great websites to help your patients and their clinicians share that decision.
And I know that I think of things in buckets as well, as Sandra just described all of those drugs. Imagine how your patients feel at diagnosis. They're sometimes like a deer in a headlight. So directing them to the IMF where resources are available and educating yourself through symposiums like this are very important to help them make the decisions that are best for them. The autologous stem cell transplant procedure remains a common standard of care for many individuals in the United States of those who are transplant eligible. So who's a transplant candidate? Why would one person get a transplant versus another? It focuses on desire, age, comorbid conditions, do you have a caregiver? Financial status is also factoring in. But we know that patients up to age 75 can be considered for a stem cell transplant, and it's generally within the first 4 to 6 cycles of any induction treatment that they should be referred, at least just for the discussion. That goes along with the whole shared decision-making paradigm. Maybe Mary just wants to do a transplant now as she's going to be getting older. She wants to just get it out of the way, check it off her list of things to do. I had a transplant, and then go on with maintenance and other drugs. Now, a very common way of treating myeloma in this day and age is a 3-drug regimen. You'll see throughout this presentation, 3 drugs in myeloma are generally better than 2 drugs if you want a deeper response, getting the protein in the blood or urine down as low as possible. This study that was led by Dr. Brian Dury of the Southwest Oncology Group, the SWOG 777 study, compared 3 drugs, bortezomib, lenalidomide, and dexamethasone versus just 2 pills, lenalidomide and dexamethasone. None of these patients had transplant. The group that had the 3 drugs only had about 6 to 8 cycles of the bortezomib before it was stopped, and then everybody just had len maintenance. The take-home point of this study is that the 3 drugs were better than 2 in keeping people in remission. We call that progression-free survival, the time that patients are in remission from starting a therapy to stopping the therapy. There was also a meta-analysis after transplant. Let's say Mary went on the transplant. We can't necessarily cure myeloma in many cases, but we can treat that clone and suppress it for as long as we can. There was a meta-analysis that was by Dr. McCarthy, looked at all the transplant studies. It showed a progression-free survival, longer remission when patients were on lenalidomide pills versus observation. So staying on medicine, just like a lot of other chronic conditions in medicine, like hypertension, diabetes, it's recommended to stay on therapy as long as possible. Now, what about if Mary doesn't want a transplant? There is information to support just staying on lenalidomide. We have a study called the FIRST trial, which was people that were non-transplant. Staying on lenalidomide kept them in remission longer. And there's a newer study that shows that there was, again, a progression-free survival benefit. People staying in remission longer when they stayed on lenalidomide. And it didn't matter the age or the risk groups, if they had high or low risk or what stage they were in. They still did better when they stayed on therapy. So that's important for nurses to encourage your patients to keep taking the medicine. And if they have side effects, then bring that to the attention of the healthcare provider. The final maintenance study I want to highlight to you is some new information. The Tourmaline MM3 study was using ixazomib. Now, this is a pill that's taken 3 times out of a month. That's it. So you think Monday, 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 then nothing. This showed that after transplant, just 3 pills a month led to what? A progression-free survival against people that didn't have it. So again, the key point in myeloma is to stay on therapy, to suppress the cancerous clones from forming so you can keep people in remission longer. Patients want to know if their treatment's working. Whether you're in the infusion center, in the outpatient, or the inpatient environment, it's important for nurses to be aware of how myeloma is monitored. Just simply, you have a protein in your blood. Educate patients as to where it is, or find out from their provider, where's my protein? Is it the blood or the urine? And then watch it go down. That's it. So if a patient comes in with too much protein like Mary, her light chains were high, we want to see that protein go down by 50% at least. That's your first remission point. That's your partial remission right here. The next remission point is the VGPR, very good partial remission, 90% reduction of protein in the blood or the urine. And then finally, in the blue areas are the deeper responses, such as complete remission. All the protein's gone, and if anybody didn't know any better, they didn't have myeloma. No protein in the blood or urine. Getting to something called minimal residual disease is really important. One of IMF's passion is prevention, and the other one is cure. And so we have lots of studies now that are trying to identify a cure. Think of it as an iceberg. The very tip of the iceberg are the blood tests that we have currently available. So here's your SSS patient, floating on the water. Hope they don't hit that iceberg. And then down here is the disease burden. We now have the ability with certain genetic tests to detect 1 in a million bone marrow plasma cells. Think about that. So in the blood and urine tests, we can only see so much, but now we have tests available to see that MRD negative status or how deep a response from therapy they have. We have studies that support doing this that say the deeper the remission you have, the more PFS, progression-free survival. That's the theme of today, right? Keeping people in remission so they can live longer and enjoy their quality of life. Patients that were MRD negative or had 1 in a million bone marrow plasma cells had a PFS or survival of 92%, and that was better than if people had measurable disease. As I mentioned, MRD testing is commercially available. clonoSEQ is one of the tests that we use quite often. It might be available in your institution. It might be reimbursed by Medicare, but it only informs us as to the remission status. We still don't know if patients should stop therapy or remain on therapy. So it gives us information, but it doesn't change our treatment decision making.
So as you've seen, it's a huge alphabet soup. I mean, even for us to keep up on all the terminology, whether it's the disease monitoring, the medications, et cetera, it's a steep learning curve for not only us, but the newly diagnosed patients with multiple myeloma. Of course, explaining things verbally, but giving them a really reliable sources of written information that they can take back, that they can refer their friends and family to. The shock of diagnosis makes understanding it even more difficult. So some of the reliable websites I'm sure many of you are already aware of, the National Cancer Institute, the American Cancer Society, the Leukemia and Lymphoma Society, but of course the International Myeloma Foundation. So if you haven't gone to their website, I really would encourage you to, because it's not only good for patient and family teaching, it's a really good source for you if you like, oh, I sort of forgot what they were talking about at the conference, hopefully not. But they not only have the website, they have teleconferences, they have all of these free brochures, and in multiple languages. Some of their core documents, like the introduction sort of to myeloma, has over like 21 languages, and that's the only organization really that I know that really is so multicultural, and so we're very proud of that. If a new medication is FDA approved, they're on it. It's on their website. So you can order these materials as well. You have an order form, or you can call up, and you can get a packet sent for new patients, but also you can keep some in your clinic so that for like newly diagnosed patients, you can have information about basic lab tests, for example. So I'd really encourage you to look on the website if you haven't already. So part of our role, of course, is specific patient education as well. And as you saw, Mary presented with bone pain and lytic lesions, and that, of course, can be life-threatening. So 85% of patients develop bone disease, even if they don't present with it. And bone destruction can lead, of course, to the hypercalcemia, leading to, of course, renal problems, and spinal cord compression is an emergency. So patients really need to know, particularly if, again, they don't present with it, signs and symptoms of a new pain, bony pain, fractures, and that they have to get it worked up and addressed immediately. Our nursing implications are we need to make sure that patients are heard and that they're provided the imaging and treatments that they need, and educating patients on not only the symptoms of bone disease, but bone health, making sure that they keep up on their bisphosphonates, that they keep up on their exercise, for example. We're not going to talk too much today about that, but really maintaining their exercise, their bone health, et cetera. And then if the patients, particularly if they're admitted, do they have lytic lesions that require us to really take into account potential for fracture if we're helping the patients with mobility.
Now, Sandra just said a minute ago, we're not going to talk too much about exercise. I just want you to know that she is a fitness queen. So one of her passions is educating about the importance of health and physical activity, and that should still be recommended to all our patients.
Yes.
When they have damage to their bone from the myeloma lesions, they still can walk, they can still swim, they can do light weight-bearing exercises, and it's important to encourage that kind of physical activity. So you might not talk about it, but I wanted to put in a jab there for the importance of exercise and healthy living, because especially the first remission that Mary gets is going to be her longest one, the best quality of life. So we want her to embrace that as well. There are American Society of Clinical Oncology guidelines that recommend how we should protect bones in myeloma. There have been numerous recommendations over the years, but a bone-modifying agent is recommended for all patients receiving anti-myeloma therapy. All patients should have their bones protected. There are 3 major drugs. We call them bone-modifying agents. The first 2 are pamidronate and zoledronic acid. They've been around for years. They shouldn't be given to patients with renal failure or a creatinine clearance of less than 30. Therefore, now we have denosumab, a monoclonal antibody that is directed to attack rank ligand in the bone, and it does show there's an increased progression-free survival among patients in a non-inferiority study that took denosumab. The really important thing to remember about these drugs is that denosumab, you need to take calcium because you can get profound hypocalcemia. Think of your other disease states such as prostate or breast cancer. Their calcium can be severely low. So I recommend to take like 2 Tums once a day, especially around the days that they have the infusion, and make sure that you're looking for renal status as well. Encourage them to have good bone health and dental health also.
Another important aspect of education of our newly diagnosed myeloma patients is renal health, of course. So patients may not understand that, well, you don't have renal problems now, but active myeloma can at any time lead to renal problems. Of course, high calcium and other medical issues if the patient also has underlying diabetes, et cetera. What patients may not understand is they say, oh, I'm urinating fine, I don't have any renal problems, but decrease in urination is not always the presenting symptom of urine problems, as you know. They often can just start to be dizzy, a little bit lethargic. Some patients can actually have leaky kidneys where they're urinating a lot. So they need to understand how to, subtle symptoms, confusion, for example, we've all seen this, but also how to prevent it. So they should question anybody who orders a imaging study with IV contrast, and of course avoid nonsteroidal anti-inflammatories. When you tell the patient to hydrate, you need to explain exactly what that is. Is it 3 large bottles of water that they bring in, or how much is that? Patients don't understand. You need to be very specific. And then for treatment is, of course, correct the underlying cause, and treating the myeloma can actually help improve renal dysfunction, as it did in Mary, and using myeloma treatments that have a quick response really helps, again, preserve kidney function. So we want to do that as long as possible, because we have seen patients, of course, that end up on dialysis. Infection prevention is probably one of the most important things in terms of our patient education, because it can be the most life-threatening for our patients. So of course the myeloma has impacted the bone marrow. Patients may become neutropenic not only from the disease, but of course from their treatments. And then, as we know, myeloma cells don't make normal immunoglobulins, so of course these patients may get hypogammaglobulinemic, further increasing their risk of an infection. So as we know, the standard is good personal hygiene. The skin is a big part of our immune system, the biggest part really, as well as good frequent oral and good hygiene. Environmental controls, of course, washing hands, avoiding crowds of sick people, good food safety practices are the standard. Prompt medical attention at the signs of infection, so any mild fever, chills, even the subtle signs of infection. So these patients, again, might be only mildly neutropenic, but they may be slightly hypogammaglobulinemic, and they may be on steroids too, which can mask infections. So I always tell my patients, you need to sort of become a germaphobe and be very, very quick to jump to something. Nobody's going to blame you for calling for any subtle sign of infection. Medications may be prescribed prophylactically, so some practitioners, depending again on the patient's level of immune suppression, may be put on levofloxacin, as well as they may be on antifungals, antivirals. Growth factors may be prescribed to reduce the severity and duration of neutropenia, and as I mentioned, if they're hypogammaglobulinemic, they may get IVIG. Immunizations are very, very important. If they're 65 or older, they'll need the Pneumovax. They'll want the seasonal inactivated influenza. Some practitioners recommend a double dose. I don't know that that's the case this year, but I've seen some practitioners order 2 doses of the influenza vaccine, and then, of course, the shingles vaccine as well. So getting back to Mary, she worked with her treatment team to come up with a treatment decision that worked best for her. She even considered available trials, and she decided on a 3-drug induction regimen, bortezomib, lenalidomide, and dex, and the lenalidomide was dosage just for her renal impairment at the beginning. Supportive agents include, she decided on the denosumab or Prolia injection, plus the calcium supplement that Beth talked about. Nursing key points, of course, again, talking about kidney function, and she had very slight kidney dysfunction, but again, we want to maintain that kidney health and the bone health. She did receive the subcutaneous bortezomib, which reduces the likelihood of peripheral neuropathy. However, we want to make sure we educated her on the signs and symptoms of neuropathy so if they occur, we can treat them promptly and make sure she maintains her treatment schedule. Dexamethasone may be given at night and in the mornings, but it needs to be given the same time each day. And her potential for a DVT is fairly low, although a little bit she does have some risk due to the lenalidomide, so a baby aspirin was prescribed for VTE prophylaxis, and then as well as acyclovir prophylaxis. So if you talk to myeloma patients, usually steroids, we speak at some patient family seminars, and steroids are the bane of their existence. They hate them. Although some spouses like them because then the patient's cleaning up the entire house. It's great. They can sit back, watch TV. But anyway, again, the myeloma the IMF has some fantastic information on understanding steroids. The important thing is steroids kill myeloma cells, and so that is really the mainstay of most of these therapies, a big part of therapy. Same as for like acute leukemia or lymphomas, very, very important. And so we need to emphasize with our patients and families, don't stop or change the dose without discussing it with your provider. Some patients tolerate them better taking them in the morning, some tolerate them better taking them in the evening, but whatever, they should be taken with food. And then proactively manage side effects if they end up with some hyperglycemia problems, making sure they have a checklist or something that they can monitor when to take it. And the doses can be adjusted with our healthcare practitioner if they do have side effects that they really can't manage. So very important. So getting back to Mary, she achieved a very good partial response after 4 cycles, so that's good. Her kidney function improved. Her creatinine went from 2.1 to 1.2. She did collect her stem cells and ended up having an autologous stem cell transplant. A maintenance therapy was planned, and minimal residual disease testing was planned for 1 year. And so at this point, it's really important that we talk about a survivorship care plan. So many of our patients will go and will get a lot of their treatment maybe at a myeloma center and then go back to their community oncologist. And so we need to make sure that we liaise very closely with these other practitioners, but that we give all that information to Mary so that she can be aware of all of her diagnosis and treatments, the follow-up plan, coordinate with the primary care provider as well as her local oncologist, and go over her long-term risks as well as her survival care plan. So in terms of maintenance therapy, patients are on therapy for a long time, as we've talked about, and so part of our role is really making sure that we help them manage the side effects, that they adhere to their treatment, and that we consider adjusting it to make sure they tolerate it as best as possible. So lenalidomide maintenance is approved for after transplant, and you may see different schedules and dosing, but she was put on maintenance therapy. Short term, there can be some side effects, but there are also long-term effects of many of these therapies, so we need to make sure they continue with all of their health care screenings, their DEXA scan for bone density, their colonoscopies, their mammograms, all those things. You know, patients don't get a free rein on these other health-related screening. And then patient advocacy, understanding, again, the patient's changing needs and desires. Part of that shared decision-making, Joseph mentioned a patient, maybe they want to, change up their treatment for a while because they want to be on an oral regimen so they can attend a wedding in another state or whatever it is. So really making sure that we work closely with our patients and make sure that our patients are heard along with the treatment team to make sure that they maintain their therapy.
So survivorship care plans are so important. In your handout, you have this sheet that the Nurse Leadership Board put together, and it has all those recommendations. It enables that communication between the local hematologist, oncologist, the primary care practitioner. We emphasize the importance of functional mobility and making sure that they continue to be active. And like Sandra said, they don't get a free pass on all their other health care conditions. There is an increased risk of secondary cancers, and it is important to make sure that they stay healthy, especially for the next treatment. So some myeloma patients, 17% will have what's called an operational cure. We are keeping them on medicine, but they're still in an excellent remission, and we don't even know what the new therapies are, how much longer they'll live in remission. The last 2 slides of this section will highlight the IMF's research initiatives. If you want to learn more about this, you can go to myeloma.org and learn about the Black Swan Initiative. Again, really stressing the importance of prevention of myeloma and cure of myeloma. MRD cure trials in smoldering myeloma, looking for MRD negativity in tests, and like the Black Swan, you thought it never existed till you saw one. We never thought a cure could be possible until we found some people are functionally cured. iStop is unique because it's examining blood samples from 140,000 adults over the age of 40 in Iceland, trying to identify and screen and monitor patients from that era. Unfortunately, most patients will not stay in remission forever. They'll go through these progression periods of remission and relapse until ultimately more clones will form that will have a hard time to manage.